Welcome to the Explainers. Today, we're unpacking a truly fascinating development in the world of orthopedics and interventional radiology. We're talking about genicular artery embolization, or GAE, for knee osteoarthritis. Now, if you follow joint health, you know the treatment landscape for OA can sometimes feel, well, stuck. You've got conservative management like physical therapy or injections on one end, and major joint replacement surgery on the other. But what if there was something right in the middle? Today, we're looking at a comprehensive scoping review from the Samsara journal that rigorously maps the evidence surrounding GAE. We'll look at the incredible early promise, the complex clinical reality, and the hard data behind it all.
It sounds a bit like a medical mystery, right? For decades, we viewed osteoarthritis primarily as a wear and tear mechanical disease, cartilage breaking down over time. But recent science highlights a totally different culprit driving the actual pain, and that's inflammation, fueled by an aberrant, abnormal blood supply. So what if instead of just treating the cartilage or masking the pain, we could physically block those rogue blood vessels and literally starve the inflammation at its source? Well, that is the exact premise of GAE.
Okay, let's dive into this. Here is our roadmap for the data we synthesized from the 184 records in the Samsara journal. We'll cover a new approach to OA, how genicular embolization works, the ideal patient profile, the placebo effect controversy, and finally, safety and future directions.
Section 1. A new approach to OA.
Millions of people are living with debilitating daily knee pain. They're often relying on chronic medications or repeated injections as they just kind of wait for their disease to progress enough to warrant a total knee replacement. Genicular artery embolization steps right into that gap as a minimally invasive endovascular intervention. Now, the literature shows us that this technique didn't actually start with osteoarthritis. Its initial applications were focused on stopping recurrent bleeding in the joint, known as hemarthrosis. But the idea spread like wildfire. Interventional radiologists realized that by targeting pathological neovascularity, these abnormal new blood vessels that form and feed inflamed joint tissue, they could address a broad spectrum of knee pathologies. Today, it's being evaluated for everything from mild to severe OA to serving as a bridge therapy for patients experiencing persistent pain even after a knee replacement. It targets the actual vascular drivers of pain.
Section 2. How genicular embolization works.
Let's move to and see how this builds, because the physiological mechanism of action here is incredibly elegant. Think of it like pruning a tree to starve a fire. Step 1 involves using imaging like cone beam CT and digital subtraction angiography to identify the aberrant genicular vessels. These are the highly specific arteries feeding the inflamed synovium. Then, step 2, the physician injects embolic agents directly into those specific vessels. The review notes a few types are used, including temporary ones like ethiodized oil emulsions and degradable starch microspheres, or permanent particle embolics. Finally, step 3 is the physiological result. By blocking that abnormal blood flow, we see a massive reduction in synovial inflammation. Preclinical models even show significantly lower synovial proliferation and T-cell infiltration. We are literally shutting off the fuel supply to the joint's inflammatory response. To understand if this actually works in humans, we need to look at how clinical success is measured. The most common metric you'll see in the data is the VAS pain score, or visual analog scale. It's a very standard measurement where patients rate their pain intensity on a line from 0 to 100 millimeters. Keep this scale in mind, because the single-arm data we're about to look at shows an absolute game changer of an impact.
In prospective cohort studies, the descriptive median VAS pain score reduction from baseline to 6 months was approximately 40 millimeters. Just think about that. We're seeing average pain scores drop from around 75 all the way down to 35. That is a highly significant, life-altering reduction in pain for patients who were previously suffering every single day, all from one minimally invasive procedure.
Section 3, the ideal patient profile. Now, what's really interesting about this slide is that GAE is not a magic bullet for absolutely everyone with a bad knee. The Samsara evidence map makes it abundantly clear that the effectiveness of this procedure is highly modulated by the severity of the disease. The most robust, replicated, independent predictor of a favorable response is a lower Kellgren-Lawrence grade, meaning mild to moderate osteoarthritis. Patients who are younger, have a higher BMI, and have less severe joint degradation show a highly favorable response. Conversely, pre-procedural MRIs showing severe OA, like full-thickness cartilage defects, large bone marrow lesions, or lateral meniscus injuries, predict a poor short-term response. Basically, GAE works best as an early intervention, stepping in before advanced, irreversible structural damage is established. This contrast is starkly illustrated in the response rates. In one study highlighted in the review, patients with mild OA saw an 81.8% clinical response rate. Compare that to just 36.4% in the moderate to severe OA group. This data is absolutely crucial for clinicians. If you use GAE as a last-ditch effort for a completely degraded joint, it is likely to fail. But if applied to the right patient at the exact right time, the success rates are remarkably high. Section 4. The placebo effect controversy. But here's where we need to look objectively at the elephant in the room: rigorous clinical proof. In medical science, single-arm studies, where everyone knows they're getting the treatment, are fantastic for early signals, but they aren't the gold standard for proving efficacy. For that, we need sham-controlled randomized trials. I want to read this directly from the Samsara Review's conclusion to ensure we capture this narrative tension perfectly. Quote, "Conflicting sham-controlled trials, a clear benefit at 1 month, yet no between-group difference at 12 months, highlights substantial uncertainty about durable efficacy beyond placebo." End quote. This right here is the crux of the debate in the interventional radiology community right now. And this brilliantly illustrates that exact point. Looking at the timeline of those trials reveals exactly what happened. At the 1-month mark in a pivotal trial, the GAA group experienced a massive 50.1 millimeter reduction in pain compared to the sham group. That's a clear, undeniable early victory. But another sham-controlled trial looked at the data at 12 months. They found that while the GAA group maintained their relief, the placebo group also experienced sustained relief, resulting in no statistically significant difference between the two groups at 1 year. Was the sustained relief in the GAE group real, or just a very powerful, long-lasting placebo effect? One trial suggested that true benefit over placebo might require absolute complete embolization of every single aberrant artery, which is technically very difficult. The debate is very much ongoing. Section 5, Safety and Future Directions. So where does that actually leave patients and doctors today? Well, fortunately, despite the debate over long-term efficacy versus placebo, the safety profile of GAE is highly encouraging. The review maps an acceptable overall safety profile with predominantly minor self-limiting adverse events. The most common side effect is transient skin discoloration, which occurs in up to 31% of cases depending on the embolic agent used. Because the vessels feeding the knee also share connections with the skin, some of the embolic agent can affect skin perfusion. However, techniques like periarticular cooling, literally just applying ice packs to the skin during the procedure, have been shown to reduce non-target cutaneous perfusion by over 73%, effectively mitigating this risk. This strong safety profile makes GAE a very viable consideration over simply watchful waiting and suffering. So, the crucial point is that to move GAE from a promising alternative to an absolute standard of care, the science has to evolve. The scoping review outlines exactly what is required next. We desperately need adequately powered, multi-center, sham-controlled trials with long-term follow-up to settle this placebo debate once and for all. We need standardized response criteria like MCID or OMERACT or ORACI, so we can accurately compare studies across the board. We need head-to-head trials to figure out if temporary or permanent embolic agents are better. And we really need to validate predictive imaging biomarkers like MRI warm scores to perfectly identify which patients will actually benefit the most before they ever enter the operating room. The data we've mapped out today shows a procedure with incredible anatomical logic, massive early pain reduction for the right patients, and a highly favorable safety profile. Yet, that shadow of the placebo effect at 12 months proves that the human body, and clinical research for that matter, is wonderfully complex. It leaves us with a provocative question as we watch this space. Will genicular artery embolization overcome these hurdles to become the new gold standard for early knee osteoarthritis, or will it remain a fascinating clinical curiosity? If you're a medical professional, a researcher, or honestly just someone passionate about the cutting edge of joint health, you really need to see this data for yourself. Dive into the complete nuances, the specific trial breakdowns, and the exact clinical parameters by reading the full 105-study evidence map published in the Samsara journal. It is an absolute masterclass in comprehensively reviewing a rapidly evolving intervention. Thank you so much for joining us for this explainer, and keep asking those hard questions about the future of medicine.